Welcome, everyone. I'm glad to see so many people are interested in this topic. It's certainly worth all of us learning more. I want to say that Pullman Regional Hospital is the hub of healthcare in Whitman County. And this evening, we're very fortunate to have 3 members of the hospital leadership who have been immersed in preparing for and dealing with this COVID-19 pandemic for the last 9 to 10 months. Maybe longer, but I'm sure for 9 to 10 months. I've asked these heroes to share with us their early planning and preparation. I wanted them to go back to before we even had any cases and share how they were way early preparing for this. They'll also talk about like testing and PPE, hospital capacity, regional cooperation, and lots more. When they agreed in September to speak at this presentation, our county had not yet had a COVID hospitalization or death. Now we've seen, according to the health department data that gets published daily, 1,867 cases as of today, 28 hospitalizations, and 19 deaths. So let me introduce our speakers tonight. We'll Scott Adams, who is the Chief Executive Order of Pullman Regional Hospital. Chief Executive Officer of Pullman Regional Hospital. Jeannie Eiler, an RN, who is the Chief Clinical Officer, and Gerald Early, MD, who is the Chief Medical and Innovation Officer. There are folks who we know who don't believe that this pandemic is real or dangerous. So I think it's very important to hear the reality of what is happening in our own community. And with that, Scott, take it away.
Thank you, Judy. It's wonderful to be with the League of Women Voters tonight. Thank you so much for inviting us. We're pleased to be able to share, I guess, a journey of sorts and what we've learned. Even though we may look like it, we weren't alive in the last pandemic. So we don't really have any experience to draw on. So we've learned in the midst of the confusion and the uncertainty and the trials. And we've learned together. And so we'll share some of that with you. We thought it would work best if we could present our information and then take questions at the end, if that's all right with the group. But we are anxious to hear your questions and hopefully offer additional information over what we've prepared. I found that for me, and I think for many of the audiences on a Zoom meeting, a few slides help the presentation to move along. So I'm going to share the screen and be able to do that for us here. And that'll keep us moving through the presentation tonight. So we do want to talk about issues related to the COVID-19 pandemic. And just as Judy had mentioned, we thought we'd start here with trying to get my slides to cooperate with me here. We'd move with a few milestones. You may remember that January 21st of this year was when the first COVID-19 case was confirmed in the state of Washington. For most of us, that probably feels like it was a couple of years ago rather than less than a year ago. But a few days later, a little more than a week, Governor Inslee declared a state of emergency in Washington. And on that same day, interestingly enough, leap day, we had our first COVID-related death in the state of Washington. So we started recognizing that this was probably something different than seasonal flu or other things that people thought it might be, but still hadn't really clicked in as to what that might entail and what the next few weeks would ultimately bring for us. So coincidentally, those events raised enough interest, at least on the part of the Board of Commissioners and the administrative staff, that at the regular meeting of the Board of Commissioners on March 4th, and Judy may remember, she's a regular attender at our meetings and a very active participant, Dr. Early provided a little overview, specifically about pandemics and what they mean and what we might be able to expect, both as an organization and in the community. And then what we were learning at that stage about the COVID-19 coronavirus and what that could signal for the types of preparations we would be looking at. But even at that point, we hadn't organized any real significant activities. We were trying to learn a little bit about what this could mean. Our infection prevention specialist had started developing some early plans and trying to share that information with us. And so as we continued down the path, we see that it was March 11th where the World Health Organization actually declared the coronavirus as a global pandemic. And so that was the first signal that this was not your normal flu season sort of event. And that began to organize and energize a lot of activities in the state and throughout the world. And so within less than a week, we'd organized our own efforts. This was a few days after Governor Inslee had closed down the public schools in the state of Washington. That was our first internal signal that we've got to better organize and prepare for what's ahead. Because we knew that closing down schools in the state of Washington was going to have an impact on our staff, and the impact on our staff would have an impact on our ability to care for patients. And so you see one of the first dominoes we were scrambling to address and understand. So we organized our Pandemic Management Coordinating Center, and it had its first meeting on March 17th, and we continue to meet today. We started off meeting twice a day, every day of the week, and we did that for a couple of months. That cadence, and I will tell you that that effort in the early weeks, we were making changes every day, sometimes multiple times a day. The information was so fast and changed so quickly that some of the things we talked about in the morning, we decided we had to make adjustments to in the afternoon. And so it was a very busy time, high anxiety, high stress, level of uncertainty continued to grow within the hospital. What I want to do now, I'm going to switch what I'm sharing for a screen. We actually put a written summary together, and I was scratching my head a few days ago trying to figure out how to best present this information. I realized I've already got a summary. I could just share that and hit some of the highlights. So that's what I'm going to do. It made it a lot easier for me, and hopefully it'll be just as helpful for you. So let me switch over to this other document. So we had divided ourselves as a management coordinating center into a few categories, and one of them was essential services and how do we prepare for the surge that might come. And so we knew that shortly after, on about March 18th or March 23rd, Governor Inslee put a halt to elective procedures in the hospitals and other facilities, predominantly to preserve very short supplies of personal protective equipment, as well as an extra precaution for healthcare staff and their safety. So we had to implement practices that would help comply with that. And but ultimately, within the guidelines, those treatments and decisions were left to between the physician and the provider and the patient as to did it qualify as an emergent or urgent procedure, or was it elective and could wait. So you'll see in a few minutes that we had a dramatic decline in a variety of services over the course of about 6 weeks. To help us do our surge and isolation planning, we called on Dr. Souvenir. He's an infectious disease physician in Lewiston, And he helped us establish our plan for isolation precautions and patient placement and how we could use the facilities that we have most effectively. We determined at that point that we felt like our ICU capacity was 4 patients on ventilators. Now, Jeannie will share with you a little bit later what we've learned about that. That was done back in March, and here we are in October, November, but our real experience with COVID positive patients started in October. And we've had to make a few adjustments that Jeannie will talk some about. We actually early on convened our ethics committee, and we had a conversation about the issues that are involved when we might have to look at limited resources. And if we have patients that we need to make choices about who might have to receive those resources that are limited, how do we make some of those decisions? There was no specific plan set for that, but it helped sort through some of the questions, maybe get a better sense of direction. Gratefully, that's not been an issue we've had to deal with thus far. As we continue on, we made decisions about involuntary psychiatric admissions. We just knew that those were things that as we got into the potential of a surge and even the undesirable status of a crisis in our hospital, that's a group of patients we would just have to work with providers to find other locations for them to go, because we would not have the capacity to include them in our efforts to care for COVID patients that we have. We got creative. We actually knew that in the PPE shortage, we might need to have other means. And so we fired up our own commercial laundry. We used some space down at Summit Therapy, which already had hookups for washers and dryers from previous times. We found the right kind of washers that could wash at the temperature we needed. And we gained the capacity to wash our own scrubs until we could increase our supply of PPE. That way, we always knew we'd have some level of protection for our staff and physicians, even when disposable supplies were in short availability. Many of you may remember, perhaps even participated in the community effort for donated masks. Now, these are community masks. These are not the medical quality masks or the N95 masks, but they are the masks that you and I wear around town. And when we're in the stores and other settings where we can't socially distance appropriately. And so we wanted to make sure that we had those in the hospital and that we became a resource to make those available in the community. And we had thousands of masks donated by people who made them. We had a little pattern that we provided, and it was a wonderful community effort. Really heartening to see the support and interest on the part of the community. We had great partnerships with WSU and Schweitzer Engineering for coming up with new designs for different types of masks and using 3D printers and other new technologies to help us create those. We pretty quickly organized and put into operation a triage and testing center that was out of actually it was a pandemic trailer that we'd received from the federal government years ago, probably during the SARS event. And so we had a trailer and a few supplies that we were able to utilize to do drive-through testing in the early parts of the pandemic. And Dr. Cliff Lightfoot and Dr. Pete Mickelson from our emergency department helped organize that. We cooperated and worked together with the physicians and providers at Palouse Medical. And we ran that testing center for several weeks until we kind of restructured down another path as we move farther into the summer. We started understanding some of the criteria for testing, and this was when we first learned that there might be GI symptoms that could also be an indicator of coronavirus infection. So we added that to our criteria. You'll see as we looked at our outpatient clinics, the pediatric practice, the Pullman Family Medicine, Palouse Heart Center and others, Palouse Medical, the OBGYN practice, we all work together as a community to say, how can we manage the care that still needs to be provided, but do it safely? So we looked at how can we switch around non-essential appointments? How can we do more phone triage? How do we make sure that the folks in the clinic settings have appropriate PPE to protect them and the patients? Telehealth blossomed as a medium for providing effective care. Some of you may have had a telehealth visit with your physician or provider, and there's still glitches in it technologically, but physicians and patients have really taken to it as an effective way that will probably persist past the pandemic. Employee screening began at the clinics as well as in the hospital. And there's an attestation process that's still done today. Visitor screening is done every day for all visitors to the hospital, which, well, actually we don't have any visitors to the hospital, all patients coming to the hospital. We made sure that there were a supply of scrubs available for all of our clinical personnel. We adjusted clinical hours, both in the ready care as well as the scheduled patients, just to better respond to the demand and decrease the workload on folks in the clinics. And then we started considering the idea of a triage tent. If you've been in to see a provider at Palouse Medical in the last 6 months, you'll notice that there's, in that lobby area out there, there's a big blue tent. And that was sort of a triage tent to keep those patients who showed symptoms or had possible exposures to COVID from being in and mixing with the non-COVID patients who were already in the office. So there were efforts to try and segregate patients to not increase the possibility of spreading the disease. From a human resource standpoint, we started developing a people resource inventory as we had services shutting down. We knew that we were not going to do layoffs. We needed our staff to provide care for patients. Even though we were in this temporary decline, we didn't want to have to try and rebuild our staff by making a short-term decision. So where could we use those folks when they weren't doing their normal job? And doing screening for staff and patients became a duty. Working in the commercial laundry that we'd organized became a place where people worked. The testing trailer that we had outside, we needed traffic control and runners to help get testing information back and forth between the lab and the testing center. So we got creative of how to have folks being productively engaged in the work we were doing. We tried to understand childcare issues and how we could support people's needs in those areas. Telecommuting and remote workplaces, as we're all doing now in one form or another, became a source of conversation. And how could we structure that? And how could we provide people with the support to be able to do that, to better meet the needs of social distancing and appropriate ways to manage people's own personal activities and personal health concerns. We began to understand some of the legislation that was passed, some of the emergency legislation around Coronavirus Response Act and unemployment rules, the work flexibility options during the pandemic, and what it looked like to develop temporary policies around time off, voluntary time off, and furloughs without pay. And so those became tools that we used in a few weeks from this time to help us manage the decline in services as mandated by the state. We put in place rules, and we dramatically restricted volunteers. Eventually, we relieved the volunteers of their duties. We currently do not have volunteers in the hospital, and that's a sad thing for us and for them. We have canceled all outside related meetings in the hospital. The only meetings that take place in our meeting rooms are those related to the work of the hospital, and then they're in a physically distanced virtual format most of the time. Visitors and vendors have had kind of a up and down way, but right now we're in a stage where we don't have any visitors in the hospital except for the birthplace, and those are limited. And vendors have to do check-ins each time they come into the hospital. Outpatients are still coming to the hospital. They get screened, but they're only here, and they're usually not, unless they need an escort or a chaperone. They can't come in with a companion unless they need someone who's a care chaperone for them. I mentioned employee screening. We do that through an online attestation, and we do that quarterly. And so we continue to keep our employees informed and updated on our expectations for what they're doing to manage their behavior. We looked at our safety and emergency preparedness circumstances. Our safety coordinator, Hannah Kimball, stays in touch with the regional resources in Central and Eastern Washington through the Disaster Management Coordinating Center. And that's how we become aware of the circumstances of bed availability and transfer capabilities, all the hospitals in Eastern and Central Washington. So we have a daily awareness of where we might be able to transfer patients if we need to, and how that factors into our care plans on a daily basis. We tried to get information out through social media, through our website. We do send out, we started with daily updates to the staff and others in the community, not everybody in the community. Maybe if League of Women Voters would like to get those updates, send me your membership email list and we'll add you to the list. Happy to send that information out. Just giving you updates about what we're dealing with, what some of our changes have been, and what we see coming down the road. So I'm gonna stop there. I've got a couple more things to say, and then I'll let you quit listening to me, and we'll go back and we'll move on to Jeannie. So one of the things that I mentioned that as we tuned into our preparations early on, the governor decided that it was necessary to preserve PPE to increase safety for staff and patients, that hospitals and other organizations that do medical procedures would eliminate all elective procedures and only do those that were considered urgent or emergent. And so as we were going along, which that graph that you see there on the top left is a weekly graph in those first few weeks of the change that happened. You see over in the normal rate and on March 5th, that first graph line there, you saw that we had a pretty good differential between the weekly revenue we brought in and the weekly costs of providing care. And then as the month got on, that started to decline and eventually dropped significantly below our cost. Our revenue dropped below our cost. And we recognized quickly, even as the governor made that announcement, that we were gonna have to make some adjustments. We estimated that we were gonna experience about a $5 million gap in our net revenue through the year because of this decline. And the impact it would have for months going forward, because it wasn't just a one-time dip. And so we said, how are we gonna manage that gap? And we began our COVID-19 emergency fund through the foundation. They began raising money. They've raised nearly $1 million toward offsetting those costs and that gap in our finances. We tracked many of the federal funds you see on the list on the right. We tracked many of the programs that were offered to help bridge these financial gaps for businesses and hospitals and other organizations. It ended up we only qualified for 2 or 3, but we investigated every one. And then, and from that, we received just over $9 million. Now, turns out all that money is just sort of rainy day money. We're going to have to pay most of that back, but we're holding on to it till we're required to pay it back without interest, just in case some bottom drops out somewhere along the line and we need a reserve of cash to help us get through that. But we also looked at cost reductions. We knew that we were going to have dramatic declines in activity. We would not be able to redistribute everyone to be productively and effectively engaged. So we developed a plan to help us manage that, where we were looking to save $1 million in 2 months. And so what that looked like was we were going to change some of our operating procedures with no time off payouts for the rest of the year. We were going to restrict how much time off people could use during this time. We were not going to do some of our payouts around Wellness for Life, at least until the end of the year. We stopped travel and education activities. We went through with the recognitions, but we didn't expend any money on the recognition events around hospital weeks or nurse excellence or physician excellence or those sorts of things. Even the recognitions around the specific hospital or recognition weeks, we decided we would not do, and we set a goal to keep organizational overtime below 1%. The biggest part, the one that was going to have the most impact, was we chose 4 pay periods starting in April, where everybody in the organization was going to take a 25% reduction in pay. Sometimes that was reduction in pay, but no reduction in hours. Most of the time it was a reduction in hours for people. But nonetheless, everybody shared in it. Physicians, administrators, nurses, janitors, everybody shared, and that was the preferred path for the organization. As we've managed economic downturns in the past, that's the way we've done it, so that everybody participates and nobody has to bear the brunt of the full brunt of the financial challenge. So we implemented those. We used reduced hours. We used furloughs. We were so effective. That was right at the height. If you remember, New Jersey and New York were just swimming in COVID patients. They were struggling to get nurses. So when we opened this up and offered furloughs, there were several of our nurses who wanted to go and help out, and they did. They went back to New York and New Jersey and were right in the midst of these COVID patients. It got to the point where we had so many volunteer to do that we were afraid we'd open the floodgates up and we weren't going to have enough nurses to care for our patients. But it all worked out fine, and we got through it. But we had some really committed people who felt like they had something they could bring to the crisis they were facing back east. So we implemented that. It was a challenge. You'll see a little bit later on the results of that. We achieved our goal, and it's been part of why we remain financially stable today. So with that, I'm going to turn it over to Jeannie Eiler to continue on with phase 2 of our efforts.
Okay, thank you, Scott. I think it's so interesting as I kind of relive those early months. And then I think we were so busy in March and April and May. And then June and July brought kind of an unusual little bit of a lull. I feel like our planning had come together. We were, and we were really not busy in the hospital. We were bringing back surgeries and what have you, but June and July were kind of gave everybody a little bit of a breather, which I think was really helpful. As we look back at our calendar, August 4th, we started back to 2 of these pandemic management meetings per week. In June and July, we dropped to 1 per week, and all of a sudden we could just get this sense things are ramping up a little bit and we need to increase so that our communication is a little bit more frequent. Right about that same time, Whitman County cases increased to more than 2 community spread patients per day of COVID positive patients. And I remember so clearly, I was in Scott's office on a Thursday afternoon about 4:30, and Palouse Medical called and said they needed to talk to Scott immediately, and they were overwhelmed by the number of people, and the majority of them being the WSU students who had returned, and they all wanted COVID tested, and they were at their outpatient urgent care clinic. And so on Thursday afternoon, we said, we need to help Palouse Medical, and we need to get our physician clinic for COVID testing back up and going. So on that Friday morning on August 22nd, we had a meeting. Our emergency director and nurse manager were there, the lab. And by about probably 2 o'clock that afternoon on August 22nd, we had the COVID testing trailer back up and going. And so that we could meet that need of people being tested and in the community. WSU had been working on testing for a long time. And I've told Scott many a time, I think I feel so lucky that we're a very small organization. We can move quickly. WSU has so many layers, and I think it's just a challenge for them to be able to move as quickly as we can. So we knew we had great testing capability, And so up and going, we did the testing. And so, starting there in on August 21st or thereabouts, this next slide will show you what happened in Whitman County and in Pullman in particular. So you see there, all along around June, July, we were running in Whitman County in Pullman about 2% COVID positive from all of our testing. Now you can see by this slide on the left, we were testing about 400 people a week. And no, I'm sorry, this is for 2 weeks. So about 200 people a week. But as soon as the middle of August came and the students started to come back, again, I think it was a little bit of an unknown for everyone because WSU had announced they were just going to be doing online classes. And so how many students are coming back? Well, August showed us that, I don't know, somewhere around 12 or 13,000 students came back, even though they were just doing online classes. So we went from about 200 people testing a week up to, in the end of August, about 800 people testing a week. And we went from about a 2% positivity rate up to a 25% positivity rate. So, I think it's pretty predictable. And then you can see it stayed kind of high for maybe about 3 or 4 weeks. And then it's been coming down, both in how much we've been testing and the positivity rate. And so I think those students, when they came back and they're back in the new environment, maybe not social distancing as much as they could or should be, but pretty soon over the next few weeks, COVID became a little more positive in our community. And so we'll get to that. But I think as you look at that there through the end of September and beginning of October, again, our positivity rate came down to about 8% overall. On the right-hand side of this slide, you can see our personal protective equipment. And in our early months, we were really concerned. We had under 400, if you go about down to the middle of this PPE slide, N95s, those are the really good respiratory protection masks. And about in May and June, we were at a place like 400 of N95s, very concerned. But we have been over 30,000 now for many, many weeks. And we feel very comfortable that we have a strong, safe supply to be able to have the right personal protective equipment for our staff. We were reprocessing some of these N95s because we didn't have enough. And we developed a way to be able to reprocess those. And then the very bottom of that right-hand slide is our in-house COVID testing. Our lab just was very progressive in how they determined different testing capabilities. And we had a laboratory analyzer that did some other kind of chemistry tests and laboratory tests. So that specific analyzer had a way to be able to do COVID testing. And so our lab director very quietly over on the side, as everybody's pushing for, we need quick results. It was taking us about 3 days to get a positive COVID result or any COVID result from where we were sending the labs out. This in-house COVID testing is about 3-hour turnaround. So we were sitting at 300 for several months, honestly. And then we started using it, and then our supply kind of dried up. Things changed in that whole supply change. That things changed so quickly. And so something that we at first thought was a precious resource. Then we got pretty comfortable that, gosh, we've got 300. That's great. Today, I heard that we have 38 of those in-house COVID tests for the 3-hour turnaround. And so we're really protecting those for those patients that really it's going to make a big difference in how we treat them for us to know whether or not they're COVID positive very, very quickly. So this September, October, as we really beefed up through the community, our testing capability, here were, hopefully all of you saw these variety of places. I think, again, Pullman is so rich in the resources that we have, and WSU, Palouse Medical, the hospital, SEL, there are a multitude of places that people can get a COVID-19 test. If you're symptomatic, you can go to a variety of places. If you're concerned about exposures, or if you just want screening, there are a variety of places. So if you haven't seen all of these, you can go to our website and you can see that very readily as well. So August and September, we started getting busier. COVID started getting a little more prevalent in our communities. And this goes back to the chart that Scott showed you at the very beginning. This is our net revenue per day compared to cost per day. So the orange line is our costs per day. They're pretty stable. You can see that. They are decreased, and our major costs are our employees. About 60 to 65% of our costs are our salaries and benefits. And compared to before COVID, we're down about 30 FTEs. And so we've brought our costs down because of our really focused cost reduction efforts. So that orange line has stayed pretty stable. And you can see in July, we never exceeded our revenue per day over cost per day. But in August, we had a couple of weeks where we had higher revenue per day than cost. In September, we had a week where we were above it. But at the end of September and October, we got really busy. And throughout October, we got really busy. And that was because people were starting to feel like they're going to have surgeries. These things are going to happen. So at the same time as our surgeries and outpatient procedures, imaging studies, all of those things, in addition to inpatient services, ramped up, our COVID admissions and COVID patient care on the inpatient side really ramped up. At the very beginning of October, maybe near the end of September, several of our assisted livings, adult family homes throughout the county started to have outbreaks. And this was a fairly predictable thing that once the students came back and we had this big influx of people, there was less social distancing. And then some of those people spread the virus throughout the community. And as I understand it, we've had a few people who happen to work in maybe in an assisted living or an adult family home, and they got coronavirus. They went to these residential facilities, and that's where these places started to get their outbreaks. And so in our assisted livings and adult family homes in Pullman and actually throughout Whitman County, we have had quite a tremendous outbreak for the long-term care facilities. Over 100, pushing 150 employees and residents of these facilities that have received or got COVID-19. And so much of our also inpatient COVID-19 inpatient utilization has been because of our long-term care outbreaks. And over on the right here, you do see there's still, we're always trying to figure out, we're looking there at about a $10 million gap. And how are we, between our salary reductions and our COVID-19 fund through the foundation, what we've gotten from the CARES Act funding and all of those things, how are we doing? And we still feel like we're over $1 million, closer to $2 million in the gap to make up those needs. But our volumes have picked up, and our main concern is just trying to still say, how can we continue to meet the needs, both of our surgeries and our procedures and our outpatient services, as well as taking care of all of the patients in our community who may contract COVID-19. So in October, October has been a really unusually busy month on our inpatient side. We've had 21 COVID positive inpatients and observation patients for a total of 98 COVID positive patient days, which really means every day in October, we had somewhere between 3 and 5 patients per day who had COVID-19, with those patients having an average of a length of stay in the hospital for 4 to 4.5 days. Now, for me, that I'm looking at these things all the time, it makes a lot of sense. But, you know, I guess I look at this, and in Pullman Hospital, we run an average of 9 patients per day. In October, we were closer to 12 patients per day, and 3 of those patients had COVID. And these COVID-19 patients have run the gamut of, I mean, everybody who doesn't have very serious symptoms really doesn't come to the hospital. These 21 patients have been seriously ill, and they take a lot of extensive, intensive care. And I'm really proud of our physicians and our nurses and our respiratory therapists and all the other staff that it takes. I think we've just done a tremendous job in taking care of these patients. I don't know if you recall back to one of Scott's first slides, we thought our surge would be to have 4 COVID patients. And honestly, in the last 3 weeks, we've had more patients than we really felt like we had the capacity to take care of, but we couldn't transfer anybody. Everybody throughout Washington and Northern Idaho is packed. They have no more capacity either. So any hospital who is feeling like they're even at their capacity can't transfer. So now we are readjusting our surge plan to say, okay, we thought 4 was the max we could take. Throughout the month of October, we took 3. And that was probably not the max we're going to see. The public health department is telling us that we need to plan for this for another 6 months. And so we're adjusting, and we're figuring out how we can continue to meet the needs of our community for the next 6 months, even if COVID continues to increase. So we're proud of our team. We're proud of all that we've done, and have a lot of strong optimism that we can continue to provide the full amount of healthcare that our community needs.
Thank you, Jeannie. I know Dr. Early has got some additional information he wants to share with the group that maybe speaks to what do we see going forward. So Dr. Early, I'm going to turn it over to you. You're muted.
I say a lot of my best things when I'm muted. So, you know, one of the things that struck me is, just as I was sitting and listening to Scott and Jeannie, is that, and as we were talking about preparation and response, is the awareness that preparation actually goes back, and in this situation in Pullman, the preparation goes back for decades. The preparation for this organization to be able to respond to this pandemic is due to that strong groundwork that's been laid by the leaders of the hospital and the leaders of this community. And that preparation also applies to the medical staff. Preparation for the medical staff goes back decades. You may not have an emergency today, but you prepare yourself for that day when you will. And I think back to the end of 2019 with no anticipation of COVID-19. It wasn't December of 2019 in Wuhan, but it was in the fall of 2019 in Pullman. And through the Society of Critical Care Medicine, we brought in some faculty from Mayo Clinic in Rochester to put on a two-day, I think it was 2-day seminar on critical care and ventilator management. How useful that turned out to be about a year later. As we learned that COVID-19 had come to the United States, one of the things that we did, we had a former professor who came and gave a lecture and a presentation on how to take care of acute respiratory distress syndrome. And ARDS, that's the disease that causes people to die from COVID-19. It's a syndrome and the multi-organ effects associated with that. Other things that the medical staff did included looking and curating, if you will, the vast amount of information that suddenly became available. Much of it wasn't peer reviewed, some of it was pre-published, and you got things coming from all directions. And it was difficult sometimes to sort out what's true and what's not, what's good and what's not, what has science and what does not, and what are the things that you would use for a patient. Well, we began to look at those things and think about it and engage in how we would utilize those tools long before we had a patient. Also, one of the things that we did was we developed an order set. That is a series of orders that we would use if, turned out when we had a COVID-19 patient. What are the diagnostic tests that you would use based upon what you have available? What are the therapeutic options that you would use? Drugs and mechanical devices and so forth. Those things sat without being used for a long period of time, but they were there. We had a long period of time in Pullman where we felt extremely protected. It felt like we had a moat around our little castle, and we were safe. Although there was an outbreak of cases in Spokane, that certainly didn't apply to our county and to our area. But things began to change. One of the things that happened was that we went along with a very low number of cases in Pullman. But then in Eastern Washington, like in many other places throughout the United States, starting in you remember in Florida, later in Missouri, and then in other places, there would be an outbreak of COVID-19 in people that were under the age of 30. Then the next thing would happen is that it would begin to spread, and it would go out and involve people that were older and older and spread wider and wider. So the first thing would be the spread of the disease, then hospitalizations a few weeks later, and then dying a few weeks later. This is came from the New York Times, was updated either today or yesterday. This is of the cases in college students in the state of Washington. So far in 40 schools in Washington, 2,896 cases. And they range from a low of 1 in Vancouver, 173 over in central Washington. There's 184 up in Cheney, Gonzaga, 115. We look down here at the University of Washington, which is a big school, a big campus, 726. But the remarkable thing that made the national news, was picked up by Associated Press, and brought Pullman to be one of the top 5 cities in the United States in terms of per capita incidence of COVID-19, was a spread of COVID-19 within the college students. Washington State University has brought a lot of wonderful gifts to Pullman in terms of economy, the culture, and the influence. This was the gift that we didn't want. But the impact of that on our community has been significant. As you all pointed out earlier, we soon had a surge in disease, an impact on the hospital, and we had our first death followed by more. This is some data that comes from the Institute for Health Metrics Evaluation. This is a foundation-funded organization that's centered at the University of Washington in Seattle. I first became aware of them early in this year. I didn't even know they existed, and I actually don't know how long they existed. The leader of the project was, I heard him speak, and then looked at some of their publications, and there's some of the data that Dr. Fauci and others use when they speak about projections and what we're looking to as we go forward. I've been following their data for many months now, and I intermittently write down what their predictions are, and I go back and take a look. And what I found is that generally, and I'll share with you actually rather disappointingly, is that they tended to underestimate the severity of disease and the impact on our state as well as on our nation. And of course, you know what's going on in our nation is just in the last 2 days, we've broke a record for the number of cases of COVID-19. We've exceeded 100,000 cases of COVID-19 per day in the last couple of days. But let's just focus on Washington. As we look here in Washington, we can see back here in February, we're kind of like, this is the daily deaths from COVID-19. We're kind of like, not much going on. You know, in February 4th, we were looking at 7 a day. And it began to rise, and it accumulates with time. And this is where we are now, where we're sitting. This is where we have effective data up to October 20th. And then the projections as we go forward, the projections now go out to February. And the projections will split when we come out to here, when we see, and it's going to be based upon what the cumulative we do. If we ease mandates regarding things that are protective, that mitigate the spread of the disease and destruction associated with it, if we continue on the same path, or if we get better. One manifestation of better is that greater than 95% of people wear a face mask all the time. So if we have universal masking, it follows this green line. And so when we follow that green line, what we see is the cumulative amount of deaths would be about 3,700. If mandates ease, it'll be as high as 5,126. This is the daily deaths, and it kind of brings it home. You can see here's where we went along with very little happening. There's that surge that we all remember at the end of March and April. And then things got cool for the state. And we here in Pullman, we were totally protected. It really didn't impact us in terms of the disease itself. Certainly had a huge amount of impact on us in multiple other ways. And then as we move forward, we see the daily deaths going up to 8 and 10 a day, 13 a day. We've actually kind of then after that peak, a little bit of a fall. And this is what's predicted to happen as we go forward and we move from here. We get out to around Christmas time, and we expect to see 27 people die a day, more than 1 per hour, just in the state of Washington. If we go to universal masking, we'll be looking at 14 a day. If we ease up, it's really going to stay about the same. And as we move out here and get out to the end of the year, on February 1st, we expect to see 59 deaths every day in the state of Washington. It could be as bad as 75. If we change what we do, it could be as good as 27 a day. This just shows the incidence of the disease, infections, and testing. This is one of the more concerning graphs for me. This is hospital resource use. And I want to take your eye to ICU beds. So one of the things that I do, and I think of it on a comparative basis, is that Washington state, even though it has 1.5 million more people than Missouri, and Missouri is where I came from, so I still pay attention to some of the stuff that goes on there and have contacts there. Even though Washington has 1.5 million more people, it doesn't have as many ICU beds as Missouri does. Doesn't have as many critical care units, and probably doesn't have the same number of trained intensivists. That's worrisome. We have 341 beds available on an average, 341 ICU beds available on an average every day in the state of Washington for people who have other diseases and problems. And this is where we were as we went along. When we got to the peak here, we actually didn't have enough beds when we got to the very beginning of April. Since then, we've done very well and come along and looking pretty good. But as we get out to, this is an unwanted Christmas present. The prediction is that by December 25th, we'll need 405 beds. We'll have 341 in the state, whole state put together. There is, and then as we go out here again to February 1st, it's predicted that we'll need 890 beds for critically ill patients, and we'll have 341. The range of that is a whole lot higher and also potentially lower. Somebody that I was showing this to the other day said, "Are you trying to scare me?" Hard not to be. This is what mask uses look like in the state of Washington. And Washington has done better than some states. Again, if I think about Missouri, Missouri's been running around 50%, 52%. In Washington, we're currently running 72%, and that's the prediction of what it will continue to be as we go forward. This is what we've done in terms of social distancing or physical distancing as we look at that. We did really good here during this first surge. That's one of the things that helped to decrease the spread of the disease when we had that first burst of the disease in the state of Washington. But we got tired. We got tired of the separation and the isolation and all the things that were associated with it. And this is where we're sitting now. And this is where we're projected to be as we move forward and look into the future. So as you look at those things, it becomes important to rethink about what are the things that I can do and that you can do and that we can do to help us decrease the spread of this disease. And it's the same things as we have heard before: social distancing, mask, hand washing. When we think about wearing a mask, there are some things that are important. All masks are not equal. One of the things that I tend to say is that generally, the more uncomfortable the mask is, probably the more effective it is. You want a mask that has 2 or 3 layers. If it's cloth, 3 layers is better. When there are 3 layers, it's a little harder to breathe through. It feels hotter on your face. If it pulls tight, it works better and gives you a better seal. And it has to be covering the mouth and the nose. And you have to be wearing it. You have to have it on all the time to be protective. Social distancing is important as well. And that becomes especially important at this time of the year. As you remember the graph that we looked at, and we saw what was occurring with social distancing, how we did so well during the first surge and how we became tired of that. And as we move forward into this period of time, and when we begin to move forward to this period of time, where we expect to far outstrip the resources that are available throughout the whole state. But still, the holidays are coming upon us. And in the holidays, that's a time when we normally long to be with people that we love and with people that love us. This year, this is a good year to stay home for Christmas. And probably to stay alone for Christmas. That's probably the safest thing that you can do. If you do something different than that, if you engage in a family gathering, I want to encourage you to do a few things. And one of them is to have the talk. So the talk is about what are the rules? And if it's your house, it's your rules. You get to make the rules because it's your house. If I come to your house, my choice is to follow your rules or not come to your house. That's just kind of part of the deal, and that needs to be part of the talk. When we think about social distancing, the common thing that we hear is 6 feet. And we think probably 6 feet is pretty darn good, especially if both people are wearing masks. The masks are effective. They're covering your mouth and your nose, and you limit your exposure to 15 minutes or so. If we have a gathering in our home, some of the things that are important is to make the visit short. Maybe make it a 30-minute visit, not an overnight visit. If we have a meal, can't eat a meal very effectively when you're wearing a mask. So if we do that, 6 feet isn't going to be near enough. And in fact, 6 feet probably isn't even enough when we're wearing masks if we're doing things like talking or laughing or those sorts of things. So we would think about when we have a meal, maybe we should be 15 feet apart. Somebody in this end of the room and somebody in that end of the room and then somebody across in the other room. Those sorts of things that are unusual and different from what we would normally do. And then the final thing is sanitation of our hands. So that out of the three, that's the least effective, but it is one more of the things that you and I can do to help prevent the spread of the disease. Soap and water, sanitary wipes, alcohol-based disinfectants, and utilizing those on frequent contact surfaces like doorknobs and pots and pans and furniture pieces and those sorts of things. The COVID-19 pandemic is going to be with us for a while, not forever. There will be a vaccine. There will be a safe and effective vaccine. We already are making preparations at the state level and at the local level of what are we going to do when we get those vaccines, how are we going to distribute them, who's going to get them. But it's not going to start out with a whole bunch of vaccines. What we have been told in the state of Washington is that we'll get 200,000 vaccines, and we don't even know which one it's going to be. There are 200 different companies that are developing them or so. A couple that are in the forefront. They're different in their application, their utilization. Some of them are single injection vaccines. Some of them are dual injection vaccines. Some of the vaccines have to be kept at super cold temperatures, some not. But whatever one it is, we've been promised that the state of Washington will get 200,000, but there's 7.5 million of us. So we won't have vaccines immediately, but we will have vaccines later on in 2021. In the intervening period of time between today and that time, we'll have to continue with some of these things that are tiresome for us, that we hate, that changed our lives so very much, but they'll help to keep you and me safe and the people that we love safe. And it's part of our pandemic preparation as we go forward. So those are the things that I had to bring to you. And if it's all right with you guys, we'll open it up to questions. And comments.
Gerald, maybe you can stop sharing your, there we go.
Okay. We have gotten in a couple of questions so far, so I can just kind of start going through those for you guys. The first one is, what about our local public schools? So I'm not sure exactly the context of that, but if you can comment at all about our Pullman schools, that would be great.
Well, I'll take a first shot at it. I can't give you
Okay.
a clinical response on it. I'm not knowledgeable or qualified. One of the things we've learned, it doesn't matter what part of the community you're in, the dynamics that we all face are so complex that trying to sit on the sidelines and suggest what other options might be considered or approaches taken is not a very productive engagement for us. We've paid attention to how do we keep the hospital safe and how do we do those things. We understand the school district's challenges. We understand we struggle with the challenges that the limited functioning of schools now creates for our staff, which then creates challenges for us. But I certainly don't have anything to suggest of what they should do different or where they should put their energies in other places than what they're currently doing. So maybe Jeannie or Dr. Early have some more clinically based input, but I know from just a practical standpoint, I'm not qualified to offer any opinion about what
I
the
got a
school
little
should
more
do.
context on that question. They wanted to know specifically if it was safe to go hybrid. So if anyone can comment on that.
Yeah, we can comment and say for sure that we don't know, I think is where I would come. When I think about the school systems, I'm really glad that I'm not in charge of making that decision. I don't have any school-age children, but I do have school-age grandchildren. One of them is suffering a lot, and one of them is suffering really severely because they don't go to school. The one who's suffering the most is the one that's most social. And our family's not alone in what we see in the manifestations of that. There are other families that truly are suffering, their children are suffering, their education is suffering, and that's a big deal. There are some people that think this is going to be a lost year of education for the children of the world. And you balance that against, that's a very obvious need, and you balance that need against, how do we keep them safe? Can kids get sick and die? And the answer is yes, they can. You know, there's only been 1,000 or 2,000 children in that 17 and under age that have died so far. But if it was one of my child, I know how I'd feel about that. And so that's part of the really hard balance. And I don't have an answer.
Okay.
Keeping the kids safe, you know, I'm a physician, and as I look at it, saving lives is really, really, really a high priority for me. And I struggle to find priorities that are higher than that.
All right. Thank you guys for the answers. Our next question is, should we consider Moscow Pullman as one area as we're isolated together and our closest hospitals are Spokane and Seattle?
I'm going to talk a lot, I guess. I got to tell you a story here. So a friend of mine was, this is about a week ago or so, and he was in an unnamed commercial establishment in Moscow. And you're supposed to wear a mask in Moscow too. And there was a couple there, a man and a woman, who weren't wearing a mask. And my friend, he didn't think that was a very good idea. And he said something to the manager, and the manager said, you know, yeah, I know, but we don't really. And so my friend, he's not obnoxious at all. He's very kind and benign, but he felt strongly enough about it. He said, you know, to this couple, he said, you really should be wearing a mask. And that's recognized as something that helps to keep everyone safer. And this guy said to him, you know, he said, we don't have to worry about that because we haven't had any deaths over in Gritman Hospital and from that, like you guys have over there in Pullman. And the reason I chuckled about it, I said, like, man, that's 8 miles apart. And that virus, it doesn't know where that state line is. So when you think about, are we the same in terms of the ability to spread the disease? I think that's kind of self-evident. Now there's variability in how the cases are reported, is my understanding, between the different counties and the degree of spread. But, and just quite frankly, and I think I'm not alone, for a long time here in Pullman, I felt like that moat, that invisible moat, was going to keep me safe. Yeah, sure was wrong.
All right. Does anyone else want to address that, or should I go on to the next one?
Next one's fine.
Alrighty. So the next person asks, based on their understanding, positivity rate is a reflection of whether the community is testing enough. Do you think we are testing enough as a community?
One of the things you'll notice, there are plenty of options to test. The health department does not encourage the nature of this virus, and Dr. Early can sure speak more to this. I've mostly learned this by listening. The nature of this virus is that a test on one day is only good for the result that day. And so to try to do surveillance testing is going to really, the resources required to do that are not available. The value of the information is questionable. But I think you can see that there's a certain conclusion you can arrive at just by our version of testing that Jeannie shared in her chart, where for the last 4 or 5 weeks, we've had variable quantities of testing, but we've stayed about 8% positivity rate. So it's probably reasonable as a working assumption to conclude that when we were 2% before school started, and now we're 8%, that's kind of the new positivity rate within the community. It's probably not lower than that. So if we tested more, we'd probably learn that it was actually higher than that, like we saw from before. So I don't think more testing, testing right, it's sort of testing in the right circumstances and for the right reasons is going to help us to protect those that are at greater risk.
I can comment on that too. You know, in my mind, ideal testing would involve every person getting at least one test a day. So at $100 a test, approximately, that'd be $36,500 per person per year for testing. And of course, that's not conceivable. There is value in testing in that it helps us to know where the disease is and where outbreaks are, and helps us to do some control, but we can't reach that ideal situation. And there is some perception that we can test our way out of this problem. Testing is a tool and is helpful.
All right, thank you guys. The next question is, are COVID positive inpatients segregated from other inpatients?
Jeannie,
you want to?
Sure, I can sure take that.
Yeah.
And you know, our in 95% of the time, they're totally segregated, and they're back in a double doored off unit, which is usually our ICU unit. But there have been some times where we've had non-COVID patients back in ICU, and we didn't want to put the COVID positive patients back there with these other intensive care patients. So we've used other appropriate rooms to put those patients in. So the goal is to keep people segregated. When the conditions aren't ideal, the people there are making really good decisions about what's the next best decision to make.
And I would add, you know, when we, there are never two patients in the room. When we have COVID positive patients, we have patients that don't have COVID disease that we know of. When we have patients, period, we want people wearing a mask. We're real sticklers about wearing the masks. And I hope you guys are too. And when you think about things again, like Thanksgiving, if you go to a gathering, if you go in a restaurant, go in there with the assumption that one of the people there has got COVID-19. If you approach it with that in your mind, it'll affect some of the things you do, and you'll do those things that are safe. You don't have to live in total fear. You just need to do all the things that you have control over. And we do that in the hospital too. Absolutely.
All right, I'll go on to the next question. Was there a reason that the pay reduction wasn't done on a sliding scale? A 25% reduction for a CNA is significantly different than a 25% reduction for a doctor.
I think I addressed that when I mentioned it the first time. We explored the various options. We knew that it was important that everybody participate in a uniform way. And there's a variety of approaches that you can take to that. And that was the one that we took. And across the salary spectrum, we had people express their appreciation for an approach that included everybody, didn't leave anybody out or exempt anybody, and that was short term. And those are the key reasons that we approached it the way we did.
I'm going to add one more thing to that too. The only place that we used the non-sliding scale was related to the senior administrative staff. And for them, it was a little bit more and a little bit longer.
All right, our next question, what are you considering for how to care for people if we run out of beds?
So the bottom line is we will do the very best we can with whatever we have that's available. And Jeannie has led some pretty remarkable planning, and she can perhaps talk about some of the things that are done to expand and use spaces for things they were never designed for, if that need is there.
Yes, I think as Dr. Early mentioned, we're meeting every day at 2 p.m. to say, what's our situation right now? What do we expect? What's our capacity for tonight when patients come into the emergency department? And what are we expecting tomorrow for our surgical patients? How and where and with whom can we best take care of those patients? And every day we're coming up with a little different solution, and every day it seems like it's working really well.
We live with that concern that we'll have many more patients than what we've ever taken care of before, and there won't be anybody else to help us out. And we're preparing for that. We're preparing for the worst and hoping for something better.
So let me put a little context on that, just for folks who might like a little bit of concrete. We have 26 rooms at the hospital, and each room has a bed. They're all private rooms. Now, under normal circumstances, 8 of those rooms are for OB patients, and 18 of those rooms are for normal med-surg patients, and then another 6 of those rooms are for, no, 8 of those rooms are for, 8.
6 and 11.
We're gonna have to get the
11.
CFO here, I guess.
Yeah. But all of those beds are available when we have a unique circumstance and we make adjustments. And we know that we're always going to preserve a certain number for deliveries. And when you get outside those beds, then the thing that we focus on those first is that all of those are true hospital beds. All of those rooms have a private bathroom, and those things are important in providing care. But if it gets beyond that, then we've got another set of rooms that they don't all have a bathroom, and they're not hospital beds, but they can be used. There's 10 of them that we could use. Now we've got to preserve some of them for infusions and blood transfusions and caring for people with other diseases, but they are available to us. So we've got this inventory of capacity. And what we do every afternoon is we say, how are we going to take the resources we have and best organize them to make sure we can provide all the care that our community needs and not have to reduce or minimize or eliminate a service.
All right, so our next question is, as businesses look at reopening, are there additional preparations staff should consider when creating and planning special operating hours, like environments to serve higher risk customers or other things?
Go ahead, Dr. Early.
So yeah, again, it's thinking of all the things that you can do to mitigate risk and exposure. And if you've got an indoor business, and in your home, if you have gatherings too, I'll go back to that again. Open the windows up, run the HVAC system and circulate the air to move the droplets that somewhere there's probably a droplet that's got a COVID-19 in it that's trying to get me or get you. So if you think of it in that approach. And there are many businesses that do, including in our community, have separate hours for higher risk individuals. Does that answer the question?
So, yeah, I also have, this was actually a comment, but I think I can formulate it as a question because it's a really interesting one. So not all tests are created equal. There are a lot of different types of COVID-19 tests. Could you comment a little bit about the ones available at the hospital?
You're on, Dr. Early.
Thank you very much. So whoever said that is absolutely right. And again, that's some of what's added to some of the confusion and difficulty with information that's available. There are, and some of the variability is dependent upon what type of test it is, antigen versus PCR, flow versus other kinds, and I can soon get outside of my area of expertise. And what's the company that put it together, and how good of a job did they do of setting up standards and controls? And there were a whole lot of tests that just by necessity that were released and made available to us to use publicly before they didn't go through the standard types of evaluation and testing of the test to verify their validity and their sensitivity and their specificity. So having said all of that, I kind of like to think of it there are two basic groups of tests. And one of them is more accurate and takes longer, and one of them is less accurate and is quicker. And so the one that's longer and more accurate, takes longer and more accurate, is what's called an RT-PCR test. And it's a polymerase chain reaction that looks for little pieces of the nucleic acids of the virus. It goes through a duplicative process so that the machines can measure it, and they do it. And there's different ways of doing that as well. Some look like they might be better than other ways. The specimens are obtained, the best specimens are obtained by putting a scope that goes down your trachea, down into your lungs, and getting a specimen. We hardly ever do that. When the next best is to put it in your nose and go back into your pharynx. That's uncomfortable. And then one that's probably just about almost as good is just in the front portion of your nose. So if that test is positive, you can pretty much rest assured that you've got the disease. And if it's negative, you can pretty much rest assured that you don't have the disease that day. The antigen test is based on a different way of measuring if you have active disease, and it can be done very quickly. That's the kind of test, if you read about in some of the massage centers and some of the airports are doing those tests. You can go up and you can get her done. We have a similar test that's more sophisticated. We have a similar antigen test within the hospital. That's what Jeannie was talking about. It's a rapid turnaround. We'll use that test if we have a patient that's coming in the hospital. We're not quite sure whether or not they got it, and we want to know right now, or have a pretty good idea right now, if they have the test, so we can decide what bed did they go in, how do we approach what we deal with the problems that lay in front of us. And the sensitivity and specificity of that test is less than the PCR test.
Right now, the bulk of the tests, in fact, we have not instituted the antigen test at this point. We're still validating its processes because it's a new capacity for us. So right now, the only tests we run are PCR tests.
Then there's the third thing is antibody testing. And that's where you test to see if within your blood you have antibodies to the coronavirus. There's a little bit of mix between this coronavirus, SARS-CoV-2 coronavirus, and all the other coronaviruses. There's several dozen other coronaviruses that intermittently have infected us humans. But that's another way to test. And it also has given us some interesting information. Antibodies are what we use to fight any type of infection. The antibodies to COVID-19, it looks like they peak and then they begin to fall away. But there are other infectious diseases that produce that response in us. Sometimes antibodies even come down to nearly undetectable levels. but still we have a heightened response to the disease upon re-exposure. And that's part of the reason that vaccines work.
Great. So we've got one more here. Do you have adequate access to the specific COVID treatment drugs used for critically ill patients?
And I can answer that as well. Yes, we do at this time. And it looks like probably we'll continue to. And what'll be interesting to see is what new drugs will we have in 2021 that will be helpful for us.
If I could just extend that a little bit, do you also have adequate access to tests? Do you feel like there's a shortage of tests, or are those available as much as you need them?
At this point in time, we are able to get adequate amount of testing. The challenge still remains is, can we get it as rapidly as we want? And can we get the type of tests that we want? So can we get the type of tests we want as rapidly as we want? And then some of it comes down then to those resources. As I said before, 1 or 2 tests for every person every day is ideal, but that's foolishness. We don't have those kinds of resources to do that. Then all we could do is test people, and we couldn't take care of anybody. You know?
In our community, in case folks didn't know, through efforts of WSU and the veterinary College of Veterinary Medicine and vet hospital and working with the state, you probably know that they've set up a testing center at WSU, and they're the production element of the samples that come in, and they do the testing and then they send the results out. So the vast majority of testing, the PCR testing, these are all the PCR testing, the higher specificity sensitivity tests, the vast majority are done at WSU, whether it's at the hospital or Palouse Medical's respiratory clinic, even the university. The majority of testing is done through that, and turnaround times vary time of day when the sample's brought in and when it's processed, but it's going to be in that 18 to 36 hour window, sometimes 48. But as Jeannie said, it used to be 72 at the start of the pandemic. We've cut that down by a half or 2/3 or more. So we've made progress, but there is still a time lag on the results.
Yeah, you know, there was a point in time, and we were complaining, not necessarily those of us whose faces we're looking at on Zoom today, but as a community and as a region, we were complaining bitterly because it would be 72 hours before we could get a test. But there were many, many other people in the state and a whole lot of people throughout the nation who it was a week or more before they would get a result. Yeah.
Looks like I have one more that I missed from earlier that I'm going to sneak back in here since we have a little bit of time. Is there a way to provide regular updates like this to the community via the daily news, the Pullman update, local radio, et cetera? I feel like the more realistic information people receive, the more likely they are to take precautions.
Hard to know how often people would want to spend 2 hours hearing about this, but I'm sure there are other avenues that if it was more frequent, it wouldn't have to take as much time to do that. So we're always open to suggestion.
You know, there are things that we do. For instance, Scott every week prepares a report and circulates that as widely as we can. On the Pullman Regional Hospital website, there are links. Some of them go to videos and blogs and things like that we prepared. We want to be communicative, and we're open to ways that we can improve that.
Awesome. That's good. We got a couple more. Is the hospital involved in contact tracing?
When we have an employee exposure, then we're the first point of contact tracing. We work in cooperation with the health department, but that's the one area where we are involved in contact tracing with our own employees.
Alrighty, that's a quick one. You talked about the expected upcoming statewide national surge, but what do you expect in terms of a winter surge locally in Pullman?
Let me just give a few dynamics that might precede what Dr. Early will offer you scientifically. We're poised to experience a similar dynamic that we did in the summer with ending of school, a fairly large gap of time when students will be away from Pullman and then will return. So we can probably expect that that dynamic will add to whatever we're experiencing just from the current rate of positivity and prevalence of the disease in the community, so that February and March could be similarly or more dramatically increased incidence of the disease in our community.
Yeah, I would add to that. I mean, the realistic expectation is that, and the evidence is in the proof that's occurred, this disease hits every place and has hit every place in the United States and in 189 other countries. It has come at different times and it's surged to different degrees. We have done much better in Washington in terms of the effect, the hospitalizations, the economic impact, and the deaths as compared to other places. But that makes me feel good, but doesn't make me feel complacent. It makes me feel proud, but it doesn't make me feel complacent. One of the things that that I learned as a heart surgeon is the value of preparing and being ready for whatever comes your way. That includes the worst thing that you can think of. I want to say one other thing too that came to my mind while we were talking. Just to mention that, because one of the concerns is about what's the spread of the disease within healthcare facilities, and that's always a concern and something we pay a great deal of attention to. There's accumulated evidence that one is that the incidence of the disease in healthcare workers is not very high. That includes in healthcare workers that take care of COVID-19 patients on a regular basis. And it makes sense when you pause and think about it for a moment, even though many of the people in healthcare are in those high-risk groups. And it relates to the practice of those three really basic important things: wearing a mask, a good quality mask, distancing when possible, careful hand hygiene, and all of those sorts of things. For a very large number of healthcare workers in our community and in the United States, they're getting the disease outside of work when they get it.
Let me just add one other thing to that. If I could just put another public health plug in. This group is probably right along the lines of preaching to the choir on this issue, but this is probably the most important flu season that we've had that people should be getting vaccinated. And the hospital took a stronger stance on that this year. There were opportunities for people to get appropriate medical exemptions, but we had 97% of our employees and physicians vaccinated this year. So we're encouraging everyone to be vaccinated for the flu this year.
I got a related question. I'm not sure if this is something you can comment on, but how many employees have tested positive for COVID at the hospital?
Jeannie, do you know?
It's a handful or so, half a dozen.
I'm done mute here. It probably is about 10 people
10.
in a variety of departments and primarily from exposures outside of the work.
And we have one more here. Is the hospital looking at other facilities to provide support in the case of an increase in cases?
We do that daily. We do that daily across Eastern Washington and Central Washington. So there's a kind of a state system set up that when you participate in that, then you're a part of a system that as you report the availability of your beds or the lack thereof, you're then putting everybody else on notice that you are available to receive patients or that you're not, and that you might be needing to look to transfer patients. And so there's a very nice interdependent system set up within the state. It's a little harder on our border state status to understand all that's going on over in Moscow and Lewiston, but we are able to communicate with those folks. Some of the transfers we've had to make in the last month have actually gone down to Lewiston because they've had some capacity. So that's been helpful. So there's both a formal and an informal process to that. Early on in the process, Dr. Early reached out to some of the folks at Sacred Heart, kind of tried to get our own little side agreement to make sure that, you know, you scratch our back, we'll scratch yours. And they were very receptive to that idea. Gratefully, we haven't had to call on it at this point, but there's several layers of interdependent activity to make sure that people have options of how to care for their patients.
All right, we've got one more in. Will the current chaos with the Spokane Health District ripple here?
The current what?
I'm not totally sure what this is referring to, but I'm hoping that somebody knows the current chaos with the Spokane Health District.
Oh, we mean with the firing of the director?
Oh,
Is that?
Yeah. You know, I'll just go out there. I think public health districts across the United States have been really challenged by this. I know public health is not well funded, and I'm pretty confident that every public health district is doing the best they can. But I think funding and politics all comes into it. And I think it's unfortunate because I think Spokane is just like so many communities that it's, Dr. Lutz has done the best he can. This is, I had an infectious disease doctor tell me in March that as an infectious disease professional, that his primary job is to hold hands of other physicians and providers, because we don't know what this new disease is going to do. And we have to be confident in what we know historically and use that knowledge to move ahead. And sometimes we make bad guesses, but you got to learn from it and move ahead. And so I think, again, this is an unknown disease, and every professional in that whole arena is doing the best they can.
Let me throw that one back at you guys. The health district in Spokane is a elected board, and one of the concerns is the politicalization of that. Any of you all got any thoughts on that?
While we're waiting for a response or two, I think to build on what Jeannie and Dr. Early have said, if you think about some of the dynamics, most of you should be aware that our own director of the health department, Troy Henderson, has submitted his resignation. He's taking another position. Now, our health officer is actually lives in Spokane, used to live in Pullman. So that doesn't change that part. But if you've got a disruption in Spokane and you got a disruption in Pullman, while ours is voluntary and peaceful, it's not controversial, it's unfortunate. And so those little bit of vacuums in that leadership could create some challenges. Now, Chris Skidmore is going to be the interim director, and he's a well-known and respected person in the health department. So hopefully we won't miss a beat. But maybe the resources we kind of shared with Spokane will be a little harder to come by until they settle down up there.
you actually preemptively answered the next question. Somebody was asking whether that resignation was going to affect the hospital at all.
Oh, here?
Mm-hmm.
Only as a trusted resource and somebody that we've known. Gratefully, Chris has been included. So this isn't a stranger that kind of takes up the reins and responsibilities as they're in the transition. So we shouldn't see much of a glitch. And so we don't see it as something that will have a direct impact on us. It shouldn't have any impact at all, really.
I've
No,
had
I
the
agree with
least
you.
experience and exposure to the people that are there, I think, perhaps, but my impression is that it's not just one person, but multiple people within our local health jurisdiction who are knowledgeable and concerned and thoughtful and helpful and collaborative. And I've been very encouraged about how they've conducted themselves and what they've done, and feel positive moving forward.
We did get a couple of responses to the question. I think generally everyone seemed to be uncomfortable with the idea of politics being involved in medical decisions. Also, I'm not sure if anyone else knows, but I don't know if we have a position on this. Bobby, do you happen to know anything about that, or any of our older members who know more specifically our positions on these things?
Lennis Watts.
Mm-hmm.
We have an extensive way to look at policy positions, and I've only been part of League of Women Voters for this last 9 months, and so I don't know if over the course of time that's been looked at all.
I think Alice is reviewing our position.
Okay.
We've got some
Right.
in the research.
So basically, we have a position which says we support a public health program for Whitman County, which promotes the physical and mental health of all residents in the county. And we've recently reviewed that in the poverty study and essentially come up with the same things, so that public health should include, that we support measures to provide access and availability of affordable health care. And this should include, but not be limited to, medical, behavioral, and dental health. So yes, we can take a position and advocate for new public health officer, expanded staffing, anything that is needed in that way.
Thanks for looking into
So
that.
call on us. Yeah, call on us if you see an issue where you'd like us to bug the local government about doing something about healthcare. We probably can support you.
Thank you.
Welcome.
All right. I think, unless anybody has any last minute ones, that we have run through all of our questions. So.
This is Judy. I'd like to thank everyone for attending and for putting forth your questions for more clarity. And our speakers were just fantastic, as I expected they would be. I just feel a lot better about our community, and I feel like the hospital's got our back and is way ahead of us in being proactive and going to do the darndest best they can to get us through this pandemic. And I like the words about masking. We all do it.
Yeah,
Thank
Judy,
you
I
so
think
much.
I think you said something that just makes me want to reiterate that. And we are really fortunate to live in a community where there is so much collaboration and coordination, and we're in a unique facility where we have a lot of resources, and I'm really proud to be a part of a community that looks out for each other, and happy to be here. Thank you for the invitation.
Yes.
And I just want to thank you as well as from the league for taking time out of your at the end of long days, I know, of work, and coming to enlighten us. And it's been so interesting. I've learned so much. And so thank you very much. And thank you for all that you do to keep us safe.
Thank you, Bob.